Good afternoon, viewers. I'm excited about today because today we're going to compare and contrast some of the common testing that people usually perform at their doctor's office to determine whether or not they are healthy or if they need some further testing. So, as you know, in the previous 3 weeks we talked about the micronutrient test and the thyroid and hormone relationship. The next one we did the cardiometabolic and correlated how patients that have thyroid and hormone dysfunction, how that will affect their cardiovascular and diabetic risk factors. And then, of course, last week we talked about the hormone panel and the thyroid panel and how those hormones are related to the nutritional deficiencies that are found on the micronutrient test. Today we're going to discuss how common tests that all of us have been trained on, the CBC, the Comprehensive Metabolic Profile, and ApoE, and how these tests will give us some indication on how we may be determine whether or not there is a thyroid dysfunction or hormone dysfunction, and how a micronutrient test ties into all of these. Because as you know, when we were all in school, we were trained on various algorithms, and usually when we were being taught laboratory diagnostics in these algorithms, we usually started out with a CBC or Comprehensive Metabolic Profile, and from there, if something was abnormal, then of course we would go down the algorithms and eventually get to more specific testing. Well, I'm going to show you today how some of the common findings on these particular panels will also lead us backwards, meaning that how we might suspect a nutritional deficiency, and that nutritional deficiency, how it may tie into our thyroid dysfunction tests and or the hormones such as testosterone, progesterone, estrogen, and so on. So once again, this is going to be looking kind of at our basic testing and go forward. Once again, as review for some of you that are just listening in today and have not listened in the previous webinars, that the micronutrient test, once again, uses the lymphocyte as the cell of testing, where, as you will see when we get into the CBC and also the Comprehensive Metabolic Profile, how that is looking at enzymes and other factors that determine organ dysfunction. As we all know, when we look at a patient as far as health, whether it's prevention or, once again, treatment, is we have to look at a lot of different things in this particular individual, whether it's the present or past history, if they're taking any medications, whether it's over-the-counter medication, prescription medication, of course the dosages, have the dosages changed, what are their dietary habits, of course, are they active or are they sedentary, what kind of job are they involved with, does their job entail a lot of stress, such as like an attorney or CPA, doctors, or some other type of profession that once again demands more nutritional status. And then, what are their sleeping habits? We know that a lot of people out there today are suffering with insomnia and are getting tested in these sleeping clinics and to see if they actually have sleep apnea or some other health condition that's affecting their sleep. Then, of course, we always have to look at genetics. And then one of the big things with the micronutrient test is the nutrient-nutrient interactions, is when you supplement someone with one particular nutrient, are you going to cause a deficiency of another nutrient, or are they going to complement each other? And then, of course, something that is going to be discussed next month when we talk about gastrointestinal relationships to the various tests available through SpectraCell, and how the absorption of nutrients are affecting someone's health as well. This is an example, once again, of a micronutrient test, and it's showing you a summation of the functional deficiencies as well as the borderline deficiencies. And we're going to get into these, once again, from a more specific standpoint on how these particular nutrient deficiencies correlate with the thyroid and or other hormones, or how hormone therapy may actually affect these particular nutrients. Once again, when you are looking at these particular results, you will see a bunch of graphs, and on these graphs there are three parts to it. There's a white portion, a yellow portion, and a blue portion. Of course, the white portion is the adequate status, the yellow portion is the borderline, and the blue portion is the deficient status. When the square indicating the patient's results is in the white, it's green. If it hits the yellow, it turns black and is, of course, noted as borderline. And then, of course, if it is located in the blue portion, it is considered deficient and it is red. The SpectraCell, I just had a patient actually today talk about this and wanted to know what really is the SpectraCell and what this indicates. This is more or less a summation of how the patient's antioxidant status is handling the free radicals in their body. And of course, we know there are a lot of different causes of free radical production, whether it's heavy metal toxicity, whether it's allergens, whether it's medications, whether it's a disease process. But whatever the case is, it's very important that we realize that we can affect the antioxidant or the free radical status with certain antioxidants. And this is one of the more difficult things to really control in the testing because it is not affected by just one nutrient. There are several nutrients that come into play when we are looking at the SpectraCell, and I'll talk about some of those later today. Another one that we look at is, of course, the Immunidex. Immunidex is a general marker of the person's immune system, and once again, we have to think of any nutrient that affects the immune system, and I'll talk about some of those today because some of those play a very strong role or relationship with thyroid as well as other hormones. And when a person does have thyroid dysfunction, how it's going to affect their nutrient status and once again affect their immune system. Just like we talked about the cardiometabolic and how we know that individuals with thyroid or other hormone dysfunction will also affect their cardiovascular or diabetic risk. So this is the first page, of course, of the micronutrient test, and this is where we're going to break it out into individual nutrients. And you can see in this particular example that most of the B vitamins are in a status that are very borderline. And even the ones that are not in the yellow and indicated by a black square, they are just barely out of the yellow and touching the yellow, and they're still green. But as you can see, generally speaking, that the B vitamins are very poor status. In my office, I like to have this square about mid-portion of the white. So there's some leeway there. And if they do come across some stress or some medication changes or some ailment, that they will have enough cushion, that they will have enough nutrient to cover that particular disease or medication or whatever the case is. So the point is that this is a strong indicator of a person that would be under stress. And this is something, once again, that we want to look at. So when you see a patient's B vitamins hovering around the borderline, or some in the borderline and some in maybe the deficient status and the others just outside the borderline, that you want to consider this person under stress, physical stress and or mental stress. Now the things that I want to point out today and how we're going to come about this later in the program is you can see in this case the person has a borderline B6, they have a borderline B12, the pantothenate's borderline, and the B2's borderline, and how these nutrients play a role or can affect your CBC. Because as we've all been trained, when a person is anemic, the thing that most people jump on right away is iron, or they might, consider B12 or folic acid. And I can show you today how there are several other nutrients that have to be looked at, and how do those nutrients play a role with, once again, your hormones. So going to the next row, you can see that we also have some nutrients that are borderline. One's inositol, and another one that's deficient, as you can see, the choline. We talked about this during the cardiovascular portion as well as last week when we talked about the importance of estrogen and choline production in the body, and how when a woman hits menopause, how her choline status usually drops. Men, once again, are more prone to choline deficiency because of the decrease in the estrogen capabilities or production of this particular nutrient, the enzyme that actually is associated with that. So once again, we know that this is a big concern in various aspects, whether it's neurological, whether it's biliary, and or whether it's muscular integrity, as we talked about with athletes a few weeks ago. So going down to the next row, you can of course see where the vitamin D is abnormal. Then we see the vitamin A that's borderline, the zinc is borderline, and magnesium is borderline. The manganese also is right there borderline. And this is a row we usually talk about with osteoporosis or osteoarthritis, or even individuals that have a lot of muscle cramps or muscle spasms, or maybe even myofasciitis. They would have several of these that are often deficient in that correlation. But once again, as I mentioned at the very beginning of this program, I'm here to correlate how these results in the micronutrient test can display themselves in a more general way on a CBC and a comprehensive metabolic profile. And that's the thing that I really want to emphasize, because to some of you, this is a very new technology. To some of you, you're maybe early into the testing with SpectraCell lab results or lab panels, and then some of you have been with SpectraCell testing for several years. But the point is, we often still perform the CBC, the comprehensive metabolic profile, and then once again, we also will talk about the ApoE and its relationship. When we talk about carbohydrate metabolism, of course, one of the things that we're always concerned about is a person diabetic? Are they insulin resistant? Are they type 1 diabetic, where they've actually had some pancreatic damage? Are they reactive hypoglycemia? What nutrients play a role in that? Are there some early indicators or possible early indicators on the CBC or comprehensive metabolic panel that, once again, will give us some clue to, yes, this will give me a lead or indicator why I need to do the micronutrient test. And I think you'll see how it's going to be strongly supported that some of the earlier findings that we are used to are not able to be determined, or you've been guessing more or less when you've seen some abnormalities on your CBCs or metabolic panel. And I'm going to show you how you're going to be able to be more specific and really get a clear-cut diagnosis and treatment plan when you use a micronutrient test with some abnormalities on a CBC or metabolic panel. One of the things that I can tell you through the years of working with SpectraCell and talking to clinicians around the country is they'll often say to me, Ron, I'm new to this testing. Who is a candidate for nutrition testing? And I always say to them, who isn't a candidate? And, of course, the reason why I say that is because for several reasons, whether it's preventative reasons or treatment of a certain pathology, we know that nutrition always plays a role in these individuals, some more than others. But the point is that we are all so used to using these general panels of the CBC and CMP that we forget about the intricacies of these particular nutrients and how they really affect some of those markers on those panels that we've all been trained on. So looking at the individual antioxidants, of course, this is the main row that everybody looks at when you are looking at the SpectraCell, as I talked about earlier, that the SpectraCell is one of the general markers that we look at to see how a person's antioxidant status is controlling or maintaining their free radicals in the body. In this particular case, you can see all of these antioxidants are normal. Vitamin C is getting close to being borderline, but once again, it is normal. So you could have an abnormal SpectraCell with a normal row like this, and you say, well, then why is that SpectraCell abnormal if these are all normal? Because once again, the SpectraCell is not just affected by this row. This is the major row that most people look at, but it is not the only row. We have to look at of course, other nutrients that have antioxidant function, zinc and copper and vitamin A and vitamin D and magnesium and glutamine and so on. So all those nutrients have to be looked at when you are trying to determine what's affecting that person's SpectraCell. It's not just this individual antioxidant row. This, of course, is a summation of what I just showed you. I showed you the individual components of this particular page and how we break it down and how we look at this. And once again, you can see on this page how the SpectraCell is abnormal, the Immunidex is abnormal, and yet the individual antioxidants are normal. But if you remember from the previous slides, that zinc was abnormal, vitamin A was once again borderline, and those are both antioxidants, as we all know, and they also have an effect on the immune system, and that's why the Immunidex and the SpectraCell are abnormal, because of those particular nutrients. So you know that giving this person extra vitamin C isn't necessarily going to improve this person's SpectraCell or the Immunidex, because this person already has adequate vitamin C status, and that's where it comes down to customizing. Now, for those of you that have used the micronutrient test, you know this is a very familiar page. When a person does have abnormal values, whether they're borderline or deficient, they're noted here on this particular page, and then individually broke out into those graphs. Of course, the deficient statuses are noted in red, and of course, the borderline are noted in blue. So now let's correlate how a simple CBC may lead you down the road to additional testing like hormone testing, whether specific like estrogen, progesterone, testosterone, or maybe a thyroid panel. And I'm going to show you how a simple CBC marker that you are very familiar with may give you some indication and relationship. Because, you know, most of us, when we talk about thyroid, we were trained at the point that, okay, if a person's overweight, if their skin's dry, if their hair's falling out, if their nails are bad, that's probably a reason for us to order a thyroid. And, of course, if they had fatigue as well. Well, as you know, that it's very important that we consider thyroid when someone complains about fatigue, but a common finding also is anemia. Is a person anemic if they are fatigued? Well, as you can see here, we know that a common finding with hypothyroidism is anemia. But the question is, what type of anemia? Is it microcytic? Is it macrocytic? Is it normocytic? And if it is one of those more or less categories, which nutrient or nutrient do we address? And how does that nutrient correlate to a possible hypothyroid status? And if I don't do a CBC, or if I perform a CBC, how is that also going to tell me additional testing? And this is where it comes back to the very beginning, and I said this at the beginning of this month as well as in September, that the micronutrient test is the baseline. That is the panel that you want to perform in order to really determine what nutrient is deficient, or if there's a combination, and or if you're giving nutrients, are you causing any problem? So taking that into consideration, one of the things, of course, we always look at when we determine anemia is the total red blood cell count. And if we have a low red blood cell count, the question is, by just looking at a low red blood cell count, what nutrient do you give? If you're just looking at a general CBC, there is no way that you're going to be able to determine which nutrient here. Now, I only picked out the nutrition-related conditions, okay? So there are a lot of other conditions that can cause a decrease in red blood cell count. For example, we know if a person has kidney damage or their end-stage renal disease, something like that, that they will have a decreased red blood cell count because of the relationship of erythropoietin in the kidney and so on. So I'm not going to cover those particular relationships. I'm only discussing the nutrient relationships today. So here's a case where you see several nutrient deficiencies, everything from the B vitamins to a mineral like iron and copper the fat-soluble nutrients like vitamin E and vitamin K. One case, vitamin K toxicity, the other vitamin E deficiency. So we have a toxicity or adverse effect with the fat-soluble. In the other case, we have a deficiency with a fat-soluble. But the point is, think about how many CBCs you've seen in your career where the person just has a low red blood cell count. Their hemoglobin may be normal. Their hematocrit, of course, is probably low as well. But some of the indices, the red blood cell indices, are normal or they might be abnormal. We'll get to those in a minute. But the point is, what did you give them? If you just ordered a B12 or you ordered a folic acid, say it's a serum B12 or serum or folic acid, look at what you've missed out. You didn't consider B6, you didn't consider iron, you didn't consider vitamin E, copper, essential fatty acids, vitamin K, of course, adverse effect, or B2 riboflavin deficiency. So in essence, you do a serum B12, you do a serum folate, and they come back normal. And what I've heard from a lot of patients, coming from other clinicians, is your anemia is not due to nutrition because we've ruled that out. We've done a B12 on you, we've done a folic acid on you, or folate. Well, you can see here, they didn't rule out, or you didn't rule out all of the deficiencies, because if you did, you would have looked at all of these possibilities. So the point is, a simple CBC with a low red blood cell count can do that. Now, you're going to see how some of these nutrients on this particular page are going to come back and correlate with, once again, hormones. So taking that in consideration, here's an example. On the previous page, we showed that iron deficiency, of course, can cause a low red blood cell count. So here you have a patient that's fatigued. They have CBC that you've ordered, and you came back with, or the results came back from the lab showing that the person has a low red blood cell count. And right away, you didn't split it out. You just said, I'm going to give you B12, or I'm going to give you folate, or I'm going to throw iron. Well, once again, you can see how iron is affected, or has an effect on thyroid, and how iodine and iron deficiency are very synergistic in the fact of they exacerbate one another. And you can see here that if you have a patient that is fatigued, has dry skin, can't sleep, can't concentrate, whatever, you might just say, based on the CBC, oh, you're anemic, that's why you're tired, that's why you can't concentrate, and you maybe never ever take it further than that. But this is a good example how when a red blood cell count is low, now you may need to go order an iron panel or an iron profile. That would give you an indication of, okay, that iron profile is abnormal. It's showing me that the ferritin is low or the total iron is low, whatever the case is on the iron profile. Now you also should say to yourself, I might have to go look at the thyroid because the thyroid is dependent upon iron. And you can see here there's some good examples in iron deficiency anemia, how low iron affects T4 levels, how it affects the conversion from T4 to T3, and once again, the TSH has been shown to be elevated. We've known this for years, and I've given you some early studies of this back in the late 90s and the early 2000s that we discovered the relationship of iron and iodine, and once again, this is where when people talk about, oh, I need to give iodine for a patient that has a thyroid problem, well, they may need iodine, but they may need iron as much or more to really correct that. So, once again, low red blood cell count on a CBC may be iron deficiency. Iron deficiency may lead you down the road to a thyroid panel. And once again, I'm going to show you some other nutrients and how they're correlated. So, as you can see from this particular slide, that the two initial steps of thyroid hormone synthesis are dependent on enzymes that are related to iron. And so here we have a biochemical, physiological connection on how one nutrient that may be kind of suspicious of with a simple CBC is giving us an idea that not only do we have to address the anemia with this person because they are fatigued, but now that anemia may be due to iron deficiency, may be causing thyroid dysfunction and causing these signs and symptoms that the patient is presenting with. I had this brilliant professor. I'll never forget this when I was going to school. And he used to always say, and of course it's common knowledge now to all of us that have been in practice for a while, but sometimes I think we try to limit certain pathologies, but he used to always say, the patient has a right to having more than one disease at one time. And that's the thing, is if we see someone that's anemic, don't stop there and say, oh, they're anemic, and let's just give them iron or let's give them B12 or whatever. Maybe that CBC indicating that anemia means that not only do they have anemia, but they also have some thyroid dysfunction or some other condition. So one of the things, of course, when we look at the CBC, we also look at the hemoglobin. And for the most part, when people think about hemoglobin, they usually think right away of iron. And once again, I'm going to show you how that comes into play here, that yes, iron is very important for the production and essential for hemoglobin synthesis, but is it the only nutrient that we really consider when we see a low hemoglobin? So you can see here is the connection of iron with hemoglobin. It is actually involved in the final step of heme synthesis, and of course then heme connects onto the globin, and that's of course how we all get the hemoglobin. So you can see it's very, very important for that final step. But there, as we know, there's several steps before that that are essential in order to make hemoglobin. So what are those nutrients, or what are some of those nutrients that really come into play? Well, one of the nutrients that comes into play with iron is copper. Copper is essential for iron uptake into the system. So if you're copper deficient, or a patient is copper deficient, they may have difficulty with iron uptake. So if you've ever had a patient and you give them iron and you say, I know this is a therapeutic dosage, it should absolutely correct that person's iron deficiency, and I'm going to give it. You give it to them, and 2 months, 3 months later, they still haven't been corrected. So you give them a little more, they still haven't been corrected. The point is, you may need to give them copper. They may be copper deficient. There is no way on a CBC that you're going to be able to determine that. And that's where you're going to need to go into the testing like Micronutrient Test to see if it's copper deficiency that's actually affecting the individual that may indirectly or directly affect the iron uptake. So you can see here that thyroid hormones have a relationship with certain enzymes, and of course the copper is bound to a protein called ceruloplasmin, of course, and this is all correlated with the rate or the function of thyroid. And usually when we see a hyperthyroid state, this is where we often see more of a copper relationship. But the point is, even with a copper deficiency in a hypothyroid state, the hypothyroid state may be that status because of iron deficiency, which is related to a copper-iron relationship. And that's why we always want to check copper if we check iron. B6, this is a nutrient that's involved in the very first step of heme synthesis. And it's due to this particular enzyme here. You can see the aminolevulinic acid synthase, and once again, it is a B6 requiring enzyme. And I put under there, you can see gluten-free diet and oral contraceptives. And you might say, why did he do that? Why did he put those particular bullets there? The reason I did that is, one, is B6 deficiency is common when a person is on a gluten-free diet. And that's very important to remember, because once again, if you put a person on a gluten-free diet, because we know that autoimmune diseases can be caused by gluten sensitivity. And so if a person has a gluten sensitivity or intolerance, it can cause a change in the GI tract, which eventually can cause some autoimmune conditions. So maybe you're thinking, okay, this person has Hashimoto's, I need to get them off of gluten. You get them off of gluten, and of course, you push them into a B6 deficiency. The B6 deficiency eventually causes an anemic state, causes a low hemoglobin, but once again, when most people think about hemoglobin levels that are low, give them iron, 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 and as a result, it's not iron, it's B6. Another thing you want to consider is oral contraceptives, or Hormone therapy, estrogen therapy can also cause B6 deficiency. And so once again, when you have an individual, maybe a woman in childbearing years and she's been on oral contraceptives for a while, or you have a woman that's in perimenopause or menopausal and she's taking estrogen therapy for her hot flashes or for some of the signs and symptoms associated with perimenopause or menopause, she may actually go into to B6 deficiency, and as a result have an anemic state. So you do some basic testing, you do CBC, you do a comprehensive metabolic panel, and there's some abnormalities there, and you'll see how I'm going to tie B6 into the comprehensive metabolic panel today and how this is a very important nutrient. As we all know, B6 is highly associated with serotonin production, and so anxiety, depression, insomnia, all those things are related. Another nutrient that plays a role with anemia on a CBC is zinc. And what's the role that zinc may play with the thyroid gland? Well, you can see here that zinc is very important for T3 binding capabilities. We also know that zinc has a role with a total T4. We know it has a role with TSH. We know that it has a connection with selenium as well as iodine. So those three nutrients should be looked at very closely. And once again, what might give us some indication that this is a nutrient that needs to be addressed from a basic CBC? Well, you can see here that a cause of anemia on a CBC could be from zinc. And zinc is essential for the second step of hemoglobin production. So as a result, and it's due to, once again, this particular enzyme, and when we look at this particular enzyme, if we are low in zinc, we can't make this enzyme. And so how many times, and think back in your career, have you actually looked at a patient, they had a low red blood cell count or maybe a low hemoglobin, right away you say, oh, low hemoglobin, I need to give them iron. You give them iron, once again, I've talked about this before, and you don't correct the hemoglobin, you don't correct the red blood cell, or even if you do, what might happen sometime is you're giving so much of iron that's actually masking, because it's correcting the hemoglobin, it's maybe correcting the red blood cell count just to get it from an abnormal value to a normal value, and so you're masking it. You're not correcting the actual deficiency, you've just improved the CBC status with the wrong nutrient because you just flooded this person with iron, and in actuality it was zinc. So when you see a low hemoglobin, you see a low red blood cell count on a CBC, once again, we know the person's anemic. Then the next question should be, what nutrient is causing that, and what in a nutrient like zinc being deficient, now we have to think about thyroid because of its relationship with the thyroid receptor and the production of T4 and the decreasing of TSH if T4 is normal. So the point is you can see that there's a strong connection from a CBC to the thyroid on certain nutrients. I showed this in the previous webinars, and once again, this is something that you want to look for. This is a classic indicator of zinc deficiency. Once again, I see this a lot in my thyroid patients, and if I see this in my thyroid patients, of course, I'm thinking zinc. I'm thinking about how it's going to affect this thyroid receptor and the conversion of T4 to T3 or the production of T4. And the whole point is, here's a physical exam finding that's not only related to the CBC in the case of a low hemoglobin, a low red blood cell count, but it's also related to a thyroid dysfunction because it involves zinc, and that's the connection. Another one, of course, we look at another indice we look at is the MCV, of course. And, of course, in your case, you've been trained that if a person has a normal MCV, that everything's fine, but it really is not from a nutritional standpoint. And this is something that we see. So you could have a decrease in red blood cell count, a decrease in hemoglobin, decrease in hematocrit, and a normal MCV, and now you, of course, have a normocytic type anemia. But you can see the nutrients involved. We talked about the relationship of copper and hyperthyroidism. You all know the relationship of selenium. And once again, the thyroid, how selenium is required to make an enzyme that actually converts T4 to T3. It can provide us, or it can cause a normocytic type of anemia in the individual. And then, of course, riboflavin. Riboflavin also, I didn't mention this earlier, but riboflavin has a relationship with iron as well. It's very important for iron uptake and utilization. Taking that in consideration, of course, we look at large cells, the large red blood cells. We know that these are the immature cells because we know that we need RNA and DNA in order to keep the maturation process going. And these are the main nutrients that we look at for that case. And once again, these nutrient deficiencies, any one of these can cause anemia. So going back to the state of the CBC, a person has a low red blood cell count and they have an elevated MCV. You could give them B12, you could give them the folic acid, but the question is, say you do a serum B12 and you do a serum folate and they come back normal. Now what do you do with that? Well, you have to look at B6 and you have to look at vitamin C. And how would you determine which one to give? Would you just, give them B6 or give them vitamin C because it's on this list? Or would you go further and order a micronutrient test, which would break it down and tell you really which one is deficient? Microcytic, once again, most people, when they see a low MCV, they think of iron. And you can see that iron deficiency is on this list, but look at the other nutrients that are on this list as well. We talked about B6 and hemoglobin production. We talked about how B6 is connected to gluten-free diets. We talked here about zinc and the relationship with thyroid receptor and T4 and TSH. We talked about copper and the relationship of iron and copper and hyperthyroidism. Riboflavin also has a role with iron. And then overall protein. Is a person consuming enough protein in it, especially if they're an elderly person? They're elderly, they're gaining weight, they're maybe going through sarcopenia, but their weight gain is adipose tissue versus lean body mass. And as a result, you do a simple CBC and you see that they're microcytic hypochromic. And if you didn't go any further than that, you just threw iron at them, you're guessing on what nutrient is, because you can see that there's 5 other nutrient deficiencies that could possibly be there with an microcytic hypochromic type anemia. When we talked about MCH, of course, as you all know, it stands for mean corpuscular hemoglobin. And once again, it is the weight of the hemoglobin per cell and the average weight. And you can see that the similar nutrients come into play. So when you see an abnormal MCH on a CBC, now you have to look at these nutrients, but then take it a step further. How do these nutrients affect hormones? How do they affect thyroid? How do they affect estrogen? How do they possibly affect testosterone or progesterone or any of those particular hormones? And we know that zinc, there's a connection of zinc and the thyroid. We know there's a connection of zinc and testosterone. So a male patient comes into you, they have anemia, and you were probably trained the same way I was. If a male over 50 years of age is anemic, one of the first things you do is you do a stool sample and you make sure that the person doesn't have something like colon cancer. Well, you do a stool sample or you even do a colonoscopy and everything comes back normal, but the person's anemic. It's a male patient. Well, what might they be deficient in? They might be deficient in iron, or they might be deficient in one of these other 3 nutrients. Maybe this male patient is on a gluten-free diet. Maybe the person's vegetarian or semi-vegetarian where they're not getting enough zinc sources, and that's causing the anemia. It's not bleeding in the GI tract. It's something like this. Take it further. The man's gaining weight, so you might say, well, his testosterone might be low. His testosterone might be low because he might be zinc deficient, but he might also have a thyroid dysfunction because of the zinc deficiency. So once again, as I mentioned earlier, any of the patients we know have looked at can have more than one pathology. In this case, it may be a low testosterone. The next thing, it might be an abnormal thyroid. An elevated MCH, of course, usually when we see an elevated MCH, we think macrocytic type anemia. Here are the relationships of that. So you can see some of those come back to play. A simple CBC, go into these deficiencies. Once again, how do those deficiencies affect hormones, or how do, once again, hormones affect these particular nutrients? MCHC, of course, this is the concentration of the hemoglobin. And as we look at this, this is how we get the color. So as we all know, when we hear microcytic, hypochromic, we know microcytic is determined by a low MCV, and hypochromic is determined by a low MCHC. Going back to these nutrients, when we see that, you can see these are the nutrients that can cause a low MCHC. Same ones can cause a low MCV. And you can see the relationship with, as we talked about earlier, going to the situation where the person has not only anemia, they have fatigue, they might have poor nail integrity, and they also may be going into a abnormal thyroid, or they may have other hormones that are being affected by these particular nutrient deficiencies. So a basic, and I say this in a very general statement, a basic CBC may give us some information to lead us down the road to advanced testing, which would include hormone testing, more specifically thyroid testing, and vitamin/mineral or other nutrient testing with the micronutrient test. So if you are using a CBC and, once again, a comprehensive metabolic panel on your patients on an annual basis for their annual physical, and you see some findings like these, this may or should stimulate you to order additional tests to see what other abnormal functions are being shown in this particular patient. Now, so sorry about that. I'm going to go back here. I apologize. Skipping a slide there. Okay, so continuing with the CBC, now we look at the overall white blood cell count. So we see a decrease in the white blood cell count, and once again, what do we think about it? Oh yeah, you have a low white blood cell count, you have a viral infection, or if you have a high white blood cell count, you have a bacterial infection. But really, if a person has a low white blood cell count, they might not have a viral infection, or they might not even have any type of infection. What they might have is a decrease in certain nutrients. And once again, when people talk about, oh, you have a low white blood cell count, you're more prone to illness. Well, that's in part due to a lot of these deficiencies, that people will have a deficiency of one or more of these, and it causes a low white blood cell count, and as a result, they don't have the white blood cells to fight viruses or fungus or bacteria and so on. And that's why you have heard over the years zinc supplementation may help with the common cold, or vitamin C may help with a bacterial or viral infection. But how many times have you heard copper or iron or glutamine or B12 or folic acid or even B6 that may enhance that as well? So once again, very important to keep in mind. So vitamin A, as I mentioned, is one of the nutrients that can actually cause a low white blood cell count, specifically a white blood cell that we'll talk about in a second. But you can see how thyroid comes into play. Thyroid function actually facilitates the conversion of the carotenoids into vitamin A. So if a person has hypothyroidism, they don't do that conversion well, and the person may have a vitamin A deficiency. So how does a vitamin A deficiency possibly present on a CBC? The person may have a low lymphocyte count. And once again, so people say, well, you have a low lymphocyte count, you may have bone marrow problems, you may have something more severe, you may have liver dysfunction, and you chase all those down and they all come back normal. And you might say, well, I don't really know what's causing it. Because if you haven't thought from a nutritional standpoint, you haven't exhausted all of the etiologies for the low lymphocyte count and or the low total white blood cell count. So once again, these common things that we've seen through the years on a CBC gives us an indication that it may be a nutritional relationship. Now, I'm going to jump into the chemistry profile, and once again, due to time restraints, there's no way I can cover all the things on the chemistry profile and how it's related to nutritional status. But I want to point out a few things that we have looked at, because one of the things that I hear a lot of times from clinicians, they'll ask me, they go, well, Ron, I have a patient that has a really low liver enzyme. The ALT is really low. And I was trained that I don't have to worry about a low level, I have to worry about an elevated level, because an elevated level of ALT may show that it's skeletal muscle, may show that it's liver dysfunction, may show that it's some other organ dysfunction. But what about a decrease in it? You can see here that B6 is required to make this particular enzyme. So a real low level of ALT, and this is difficult to really look at because, as you know, in most labs, they don't give you the bottom. They just say less than 42 or less than 38 or less than 40, whatever your lab uses as the marker for ALT. And some may even say 0 to 42. And you might have a patient that has a 2. You say, well, that's good. That means you don't have liver dysfunction. Well, that's not necessarily good. They can have a low ALT because of a B6 deficiency. So think about this, how this comes into play. A person's on a gluten-free diet. The person has an anemic state. They have a low hemoglobin, and they have a low ALT. Now, you're going to do something about the hemoglobin and the red blood cell count and that, but you look over at the comprehensive metabolic panel, and you're not going to do anything with that because you see that the ALT is well within normal range, but it's at the very low end of the range. So it's further confirming that you have a B6 deficiency. On the other hand, if you're supplementing someone with vitamin A or you're giving them nicotinic acid for lipid control, we know that the ALT can be elevated. And so this is one of the products that we watch if we do decide to use niacin in combination or in place of a statin. AST, we know, once again, this is another so-called liver enzyme, but as we all know, that AST and ALT are not just located in the liver, that they're located in different tissues, and skeletal muscle is another tissue that we look at when we are looking at these two enzymes. Same thing here, B6 deficiency can cause a decrease in the serum AST. An increase, once again, may be due to vitamin A toxicity, nicotinic acid, side effect, and or iron overload. So here's a case of an iron excess due to this particular condition, the hemochromatosis, that may be affecting the AST. So this is a nutritional relationship. Albumin, for all of us probably in the healthcare field, we've always looked at albumin as the marker of protein nutrition, protein status. As you can see, it has a half-life of about 18 days, so really you're not going to change the protein status, so you're not going to be able to recognize protein status changes if you give someone additional protein for at least 18 days. But look at this. What about a low serum albumin that's not protein related? Maybe related to vitamin C, maybe an iron deficiency, and I've given some other conditions, of course, nephrotic syndrome or liver disease, where we have the iron overload that may also affect the albumin. Then we have alkaline phosphatase. Everybody usually worries about an elevated alkaline phosphatase. It may be liver involvement. It may be bone involvement. It may be intestinal involvement, depending on if we look at the alkaline phosphatase isoenzymes to determine what specific tissue involved. But you can see here that a decrease, a real low level or low normal level of alkaline phosphatase on a comprehensive metabolic panel actually may lead us to these deficiencies. How would we determine that? We would do that once again with a micronutrient test. How does that relate to the hormones? This particular month that we're talking about thyroid and other hormone dysfunctions, we know that zinc affects thyroid, as we talked about. Zinc affects testosterone. We know that B12 and folic acid can affect thyroid. We know that protein can affect thyroid as well as other hormones. So we have to look at some of these general tests like the CMP and the CBC and look at the low end of these enzyme levels, not just always are they elevated. The last thing I want to talk about is really the ApoE testing that SpectraCell does. And what's important about this is how this correlates with cardiovascular disease, and of course how you will hear in a few months how it also correlates with neurological diseases. But the point is this is a genetic test that a patient, once again, only has to perform one time, because once we know what their lipoprotein E genotype is, that will give us a better indication of whether or not they're going to respond to our particular type of therapy. And so you probably have heard this from patients that they've said, oh yeah, that doctor, or you might have had the patient say, okay doctor, I've been on Lipitor or I've been on red yeast rice, and that particular medication or that particular herbal product really hasn't lowered my cholesterol well. I know it's supposed to do that, but it hasn't done that. Well, once again, this is where the apolipoprotein E genotype testing comes into play. That if it was an individual that had this E3, E4, you can see here that they do not necessarily respond well to stat therapies, whether it is red yeast rice or whether it is a prescription statin. But once again, they do have a good response to a low-fat diet. So this is a situation where we get them to exercise, we get them on a low-fat diet, and their cholesterol and other cardiovascular monitors come down. Once again, this is complementary of thyroid, because we know that thyroid dysfunction has a relationship with cardiovascular disease. But on the same hand, it also may help us determine, are there some other nutritional deficiencies that, if corrected, could affect that person's lipid, whether it's a lipid particle like lipoprotein A or the dense 3, the dense 4, something like that. But by performing this genetic test, we have a good idea on, before we even start a person on a statin and or red yeast rice, if they're going to respond well or not. If we don't think they're going to respond well on it, we don't put them on that medication or that herbal product. We may look into some other testing. Or what are some other nutrients that can have a play with that person's cardiovascular disease? Well, we know vitamin C has a role. We know magnesium has a role. We know that some of the B vitamins have a role with homocysteine relationship. We know that selenium has some role to play with the regulation of the LDL and HDL. Chromium has a role. So there are other nutrients that can help lower cardiovascular disease and also are connected to the thyroid or other hormones. But once again, it's genetic testing that is very, very important to the individuals. In addition to that paragraph there, you will see that there is a little bit more of an interpretation that gives you as a clinician more to talk about with your patient on what's really involved and why this is important. And once again, something that's going to show your patient that what you gave to them earlier, whether it's a prescription statin or red yeast rice, didn't really work. And the reason why it didn't work is because of the genetic makeup of that individual. And this is where you have to change your treatment plan and try to address other nutrient deficiencies, or maybe incorporate more exercise or dietary changes. But whatever the case is, it's very important that they realize that there can be some genetic correlations, and one therapy for one individual isn't necessarily going to be beneficial for the next individual. And we've all had those patients where they come in and say, well, my neighbor comes to you and you gave them that medication or you gave them that nutrient, and their condition improved significantly. We do the same thing with the next individual, and it doesn't work. And once again, we know it could be genetics, it could be some other major factors coming into play. So the main thing that I really want to emphasize today is how some basic testing, the CBC, the Comprehensive Metabolic Panel, can give you an early indication of some nutrient involvement and how those nutrient involvements, whether it's zinc or iron or copper or whatever nutrient we talked about today and showed you in these slides, has a possible role with other tissues or organs that may lead you down the road to discovering another pathology or abnormality with that patient. So that's the main point that I really want to emphasize, is the CBC and CMP and even the ApoE are just tests that should lead us down to additional findings that can really get to the root of the problem. And going back to the micronutrient test and how that connects all the dots to the cardiometabolic, to the thyroid panel, the hormone panel, the ApoE, the CBC, the CMP, and why that should be the baseline test to really give you specific, customized therapy. I want to thank you once again for your time. Once again, as you know, this will be archived and can be listened to at another time and several times down the road if you want to review this. But I think it's very important that a common testing procedure as a CBC or CMP can give us some early warning of something else that's going on, but we can specifically answer those abnormalities on those panels with further testing. Thanks again, and have a great day.